Welcome to episode 4 of the TVN Together 7 Things You Need to Know About Pressure Ulcer Prevention. Now I'll shortly hand you over to Amy and Carol, who are going to discuss the importance of mobility and keeping moving to prevent pressure ulcers. Amy Verdon is a tissue viability clinical nurse specialist at University Hospitals Coventry and Warwickshire NHS Trust in England. And Carol Jeffrey is a tissue viability nurse for primary and acute care in NHS Lothian, Scotland. Over to you, ladies.
Thanks very much, Jenny, for the introductions. We hope that you've enjoyed the sessions from the other TVNs from the UK so far on risk assessment, skin inspection and care, and support surface selection and use. Carol and I look forward to sharing our knowledge through this next session on keeping patients moving to prevent pressure ulcers.
So let's get started. The aim of our short session is to share tips and skills that can help to keep patients moving. The session is aimed at anyone who is caring for someone who needs to keep moving to prevent pressure ulcers, and will also be useful to any individual who thinks that they need to keep themselves moving a bit more.
So why do we have to keep moving? Well, we do it to ensure that our patients are comfortable and pain-free as much as is possible. Ask yourself, how long could you sit or lie in the same position before becoming really uncomfortable? And it's also really important to move regularly to a range of different positions to maintain a healthy posture, maintain our limb flexion, and ensure that we don't lose muscle strength.
We move our patients regularly to assess their skin and pick up any areas of discoloration or damage. Pressure damage can develop very quickly in someone who is at high risk. If the risk is assessed quickly and appropriate prevention strategies put in place, this can prevent damage. Patients can be admitted with pre-existing damage that is often not known about or is at a different grade or category from that which is handed over, and this also needs to be detected early to put appropriate management prevention strategies in place. Every time we move our patients, a quick skin assessment should take place of the at-risk areas, which only takes a few seconds. Remember to not just check the sacrum and heels. If a patient has TED or compression stockings or bandages in place, remember to take them off and check for damage underneath.
So we need to keep moving to relieve the pressure over the bony prominences. The tissue over these areas can have the highest pressure applied to it, and therefore it has to be relieved to prevent skin changes, as in blanching erythema or redness, or deep tissue damage, as in purple discoloration, such as in someone who has had a long lie and lay in the same position for a sustained period of time. An example being somebody who's collapsed at home on the floor and was unable to get up and get help for many hours or sometimes even days. If the blood flow to the tissues is compromised for too long, then the tissue can become quite hypoxic and start an inflammatory process, and then damage begins to show as discoloration on the skin, or in the case of patients with darker skin, the skin can feel warmer or spongy or cooler to touch.
Who does it affect? From neonates with very thin, underdeveloped skin, to wheelchair users who, as well as not being able to feel the pain or discomfort of developing damage, may also be unable to reposition themselves, to pregnant women in labour whose skin can be affected by moisture, with sustained periods of lying in the same position, shearing and friction whilst repositioning themselves, and epidural use which will prevent awareness of the sensations required to trigger a position change. Chronic conditions where either the sensation to the skin, circulation to the tissues, or the ability to reposition themselves is impaired. Elderly people, their skin is thinner and more susceptible to shearing forces. This can be compounded by dehydration, poorer diet, reduced mobility, polypharmacy, or they may be less cognitively aware of pain or damage. Anyone who is suffering ill health with a compromised diet, fluid intake, pyrexia and sweating with reduced mobility is at risk and needs to be repositioned more regularly.
So from a healthcare professional's perspective, who does it affect? Essentially anyone providing care, and this can range from hospital medics or GPs, hospital or community nurses, paramedics, therapists, operating department practitioners, and healthcare assistants. It is everyone's responsibility to use any opportunity possible to ensure patients are given the right information about how to keep moving to prevent pressure ulcers. Even a non-clinician, such as a domestic or receptionist, could report to a healthcare professional that it appears that someone needs more help than they normally appear to require. And good communication is key to all of this between healthcare professionals.
Patients need to know that we are there to help them. Years ago, I had a patient on my community caseload with a toe wound who had not been assessed for pressure damage because we were seeing him for a toe wound. Weeks into his treatment, when he had developed a relationship where he felt he could discuss it with me, he told me that he had a really sore bottom. He actually had a nasty grade 3 pressure ulcer on his sacrum because his mattress was terrible, he was frail, and he was less mobile than normal. A new mattress was ordered for him, and we taught him how to change his position and lie on his sides to help his wound heal. Relatives need to be taught what to look out for in the way of skin damage, how to safely and correctly move and handle their family member, and the implications of what happens if this is not done correctly. Educate them on what to do and who to seek support from if damage is noticed. They should be supplied with education, information, and support, such as leaflets or online information. Carers, some of my best information highlighting patients that are at risk or who have developed damage or inappropriate moving and handling practices being performed have been provided by carers.
So, where can we keep people moving? In a hospital setting, essentially everywhere, from those initial interventions and assessments in the emergency department to a more long-term documented positioning plan in our wards and critical care settings. We should also not forget the importance of keeping moving in our short stay or outpatient settings, where patients can still be vulnerable, such as dialysis units, outpatient clinics, plaster rooms, and radiology units. Pressure ulcers can occur anywhere and have been seen following a long clinic appointment with multiple episodes of waiting for an ambulance, sitting on an ambulance collecting other patients, waiting for the actual appointment or additional tests, and then waiting again for transport home, all of which sat in an old, poorly fitting, borrowed wheelchair without a suitable cushion, for example, when at the home the patient has a plethora of equipment in use.
It's always a good idea in primary care to observe caregivers, especially relatives, changing people's position, as it can sometimes require some re-education and support. I've seen some family members lift their loved ones rather than hoist them, which puts their backs at risk, as well as increasing the friction and shear on the person at risk. There are some poor moving and handling techniques used due to either poor initial education of how to move and handle correctly and safely, or relatives who have been trained correctly thinking their way is easier without realising that they're actually causing damage to the person's skin. Some people are left sitting up for too long, with family reluctant to allow carers in to augment the care that they can give, as it is intrusive, or they feel that they want to provide all the care for their loved ones. If people are sat for too long on shower chairs or commodes which are not correctly padded, that can also lead to damage. Sometimes there are difficult work-life balance issues for people with pressure damage. It's not in the patient's pressure area's best interest to, for example, go out in the car, but this can be the highlight of their week and be essential for their mental health. It's sometimes a compromise in people with chronic conditions between physical and mental well-being.
So at the heart of the resources that are used to facilitate the patient to keep moving is the patient themselves and their knowledge, their ability and willingness to participate in keeping moving to prevent pressure ulcers. In order to move people correctly and safely as health professionals, we need to use the correct equipment. And this can be as simple as the use of a walking stick or wheeled walker to a rise recliner chair, through to more complex equipment such as glide sheets, standing aids like a rotunda or Sarah Steady, hoists, dynamic mattresses, tilting platforms, and repositioning mattresses. We also need to consider devices specifically for heels, such as offloading boots, wedges, and pillows. And if a patient is completely immobile and needs to be placed into a 30-degree tilt, then you'll need lots of pillows for repositioning purposes. If a patient cannot be repositioned easily, such as a patient with an unstable spinal injury, then devices such as silicone gel pads can be really useful on intact skin on vulnerable places to support prevention. And these can also be used, for example, in a contracted hand to reduce pressure. All of this, however, is less important if it isn't documented to evidence the care that you've provided and the education given to the patient. This can be done using care rounds, skin bundles, or repositioning charts, depending on what is in use within your organisation.
The most important resource are human resources, staff, carers, and family. Ensure that there are the appropriate number of correctly trained people to safely change the person's position. In Lothian, we educate all new trained staff during their induction week about pressure ulcer prevention, including moving and handling updates. Reminders, prompts from a pink card saying think pink to a clock face with a time that the person is due turned next on the bed head or information board. A community hospital in which I implemented the skin bundle had a central list with times that pressure area care was due for all the patients requiring it in the ward. This was checked regularly and reviewed and updated at regular intervals, and this optimised achieving timely position changes. Intentional rounding charts now document this, but there is scope for different tools to support the best care provision. Think about whether this works well in your clinical area or if it might need improvement, and if so, what might work best to support the provision of the best pressure prevention. Would it help to set an alarm, have a reminder, have a prompt to support timely repositioning?
So, when should it happen? Well, firstly, positioning must be patient-centred. It absolutely depends on the patient's risk, but at any moment of opportunity, you should ensure that the patient is repositioned, educated, and aware of a plan of repositioning. It should be performed as often as is needed to prevent colour changes developing on the patient's skin. And it's usually advised every 2 to 4 hours in a hospital setting, for example, but this will depend on the risk of the patient to developing skin damage and, as I say, on the clinical setting, whether that's an acute hospital, community setting or hospice, for example.
If the skin condition is improving, you can reduce the time frequency. If skin is still marking or is deteriorating, reassess and increase the frequency of repositioning and consider whether other measures are also required. If there is a change in the patient's clinical condition or circumstances, a review of frequency of repositioning should be done. In community, the maximum care package that people can have is 4 times a day and sometimes overnight support, but not everywhere. Other methods of repositioning may be required to augment this, such as tilting mattresses or tilting platforms for underneath mattresses. Always remember to document the patient's repositioning regime and any patient or carer education that you've given about repositioning.
So keep moving. How should it happen? Firstly, we need to look at the patient, their environment, and also the equipment that's in use currently and any additional equipment that you might need. We need to listen to our patient's wishes and also the team and what has happened previously. Don't reinvent the wheel. Learn from any mistakes that have happened in regards to keeping patients moving, either within the ward or within a department or with the individual patient, and share knowledge. We should learn and read the patient's clinical notes, ask questions and take a thorough history. You can learn so much from talking to patients, relatives and carers. And finally, implement a repositioning regime for all immobile patients.
Encourage self-caring patients to keep moving. Equip them with knowledge to understand why, and they may need this information reinforced or reminded regularly. For example, when their TV programme ends or when the hourly clock chimes, get up, stand, let the blood flow, change your position. With the help of appropriate equipment as outlined by Amy. Document how each patient will be repositioned or will reposition themselves.
So what do we do if a patient cannot keep moving? Well, the first important question to ask in the first instance is why? Why are they not moving? Are they in pain? And is it as simple as we can give them additional analgesia? Are they distressed? Have they had a previous poor experience of keeping moving? Or is there a lack of equipment or a lack of staff to facilitate the patient to be able to keep moving? Are there any gaps in the knowledge of the patient as an individual or staff as to why they need to keep moving? Or is it that you've got a non-concordant patient? Do we need to consider mental capacity assessments to determine, are they making an unwise decision or do they lack capacity to make a decision? Do you need to utilise best interest decisions, deprivation of liberty safeguards or incapacity? And if the patient doesn't concord with the proposed care plan, after thorough discussion, ensure that they understand the consequences of that non-concordance and document the discussion. Ensure as well that you use any specific refusal of care paperwork in your organisation to formalise this decision.
If relatives do not concord with delivering the care plan, ensure that they understand the consequences of their non-concordance and document any discussions. Discuss with patients and consider if they need to have vulnerable adult status and require to be referred for social work support. Complete a DATEX to document and highlight the issue. Is it a safeguarding concern? You may need to escalate this. Ensure safety of your patient at all time. It's a key roles of being a nurse, prevention of harm, and being a patient's advocate.
So what can happen if we don't keep our patients moving? If the required care is not implemented, then the risk is that the patient then can go on to develop a pressure ulcer. This can range in severity from an area of red, non-blanching skin, right through to a significant cavity wound with bone exposed. And this can affect patients in different ways. This increases their risk of further complications, such as a prolonged hospital stay, or they may require admission to an acute hospital setting. They may require surgery, might develop an infection or suffer an amputation, or at worst, they may die as a result of a pressure ulcer that has developed due to not moving regularly enough. Their physical health can be affected and it may affect their mobility. They may not have any desire to eat and drink because ultimately they're living with a wound 24/7, and therefore their physical health and quality of life can be severely affected. They may not be able to work, their family life and ability to socially interact and function in a community can be severely hampered.
From a professional perspective, there is an increased risk of investigations, root cause analysis, safeguarding issues, and it may go as far as the coroner. As a healthcare professional, you may be in breach of your professional code of conduct if acts or omissions of care were noted that led to the development of pressure damage. DATEX reporting of incidents, or in care homes, care commission reports, will start a root cause analysis of the issue and support resolving the issue. Was it due to staffing, educational requirements, lack of equipment, etc.? This leads on to improvement and prevention of recurrence of the issue.
So, to summarise our presentation, we would like to remind the audience of the importance of keeping patients moving, educating them at every opportunity as to the reasons why, and ensure as health professionals that you are knowledgeable and have the correct resources to keep your patients safe and to protect their skin from developing pressure ulcers. Prevention of harm is key for all health professionals. Thank you so much for listening and learning all about keeping patients moving to prevent pressure ulcers.
Thank you. Bye.
Thank you, Amy and Carol, for an informative session on the importance of mobility and keeping moving in the prevention of pressure ulcers. Now, it sounds relatively simple that if we reposition our patients regularly, then the patient's skin will receive enough oxygen to prevent pressure ulcers from happening. But we all know that implementing and sustaining an adequate repositioning regime for patients is far more complex. Now join us next week for episode 5 with Jilly and Shona, who are going to talk about the importance of managing continence and increased moisture on the skin in the prevention of pressure ulcers. Now a date for your diary, November 19th at 7:30 p.m. TVN Together will be streaming live from the Journal of Community Nursing's Facebook page, where you will have the opportunity to ask TVN Together any questions you may have around pressure ulcer prevention. See you next week.